Thanks everybody for joining us again for one more seminar, part of the Kirby Institute seminar series. You may know me, I'm Susana Vajneri. I lead the NTD research group in the Global Health Program. And I'd like to start by acknowledging the Beregal people, who are the traditional custodians of this land from where we are joining this video seminar. I'd also like to pay my respects to the elders, both past and present, and extend that respect to other Aboriginal and Torres Strait Islanders who may be joining here today as well. So the usual housekeeping rules. So we are online. I mean, some of us are here in the room, but so we'll start with the presentation, followed by questions and answers at the end. You can ask questions through clicking on the Q&A icon at the bottom of the screen as usual, and feel free to ask questions at the end, people who are in the room. So this is, I'm very, very happy that I have Luc Coffeng here with me today. We've been collaborating for a long time now, 7 years or something like that. So Luc Coffeng is an assistant professor at the Department of Public Health, Erasmus Medical Center at University Medical Center of Rotterdam in the Netherlands. And Luc, I mean, we've been collaborating through our common interest in neglected tropical diseases. His work is primarily focused on informing public health policy, decision-making, and study design for the control of various NTDs using mathematical models to integrate knowledge from different disciplines. Welcome, Luc. It's been a pleasure having you for the last 3 weeks, and very happy to have you teach us about mathematical modeling.
Thank you, Susanna. Thank you. I would like to also acknowledge the Beregal people and pay my respects to elders past and present. Let me share my screen. Welcome, everybody. Thank you for having me. It's been really great to visit Sydney for a month. I've been here for 3 weeks now. I have 1 more week to go. I'm very excited to tell you a little bit about my work as a mathematical modeler and epidemiologist. Some of you have already heard some of this during the Global Health Program review meeting last week, but today I'll go a little bit more in depth. So my background is medicine. I was trained as a medical doctor, but quickly changed to infectious disease epidemiology and mathematical modeling, which I learned really at Erasmus MC in Rotterdam. But over the last decade, I've worked a lot with other field researchers, epidemiologists around the world, including Susanna. I'm based in Rotterdam, in the Netherlands. This is our institute. You can see in the back across the Maas is Kop van Zuid, the head of the south. It's the hip area of Rotterdam that we from the north affectionately call the bottom end of the north. This is where the cool stuff happens. We are the Department of Public Health of the Division of Health Sciences. We are about 150 people strong, with half of them, about half of them being PhD students. Our work primarily focuses on the area of Rotterdam, but also Netherlands and Europe, and globally, in particular, low and middle income countries, which is what my work focuses on. And our department constitutes several research lines in primary and secondary prevention. And I'm in the Infectious Disease Control Unit. We're a relatively small group of fluctuating size, about 20 people at the moment. The focus of our work is really to inform public health policy and study design, but also evaluate and predict the impact of different interventions and control programs. And the main techniques that we use are mathematical modeling, but also in general, quantitative analysis of infectious disease dynamics in populations. We work on a range of infectious diseases, including neglected tropical diseases, which I will focus on today, but also other major infectious diseases like HIV, TB, and malaria, and lately COVID. So today I want to go through 3 case studies with you, with which I hope to show you the power or the usefulness of mathematical models and simulation for public health policy. And these 3 case studies, I chose them to show how these methods can help us understand the effects of control efforts, but also inform guidelines and study design. And then third, predict the impact of past, current, and future control efforts. And I'll use 3 different NTDs to showcase that. Visceral leishmaniasis, soil transmitted helminths, and onchocerciasis, also known as river blindness. We'll start with visceral leishmaniasis. This case study focuses on the role of indoor residual spraying to control the vector that transmits VL. VL is transmitted by sandflies. It's a protozoan. In the Indian subcontinent, which I'm focusing on for now, it is completely anthropogenic, at least it's thought to be. It presents rather, the presentation is rather aspecific. It's just fever mostly, and then after a while people get an enlarged spleen, and if left untreated for months, people will eventually die. Once they are detected and treated, though, a small percentage will develop a syndrome called post-Kala-Azar dermal leishmaniasis, which is a rather people don't have any complaints of it. It's a very superficial skin infection, but it is infectious towards the sandflies, and it lasts for years. So people are not motivated necessarily to seek care or treatment and form a reservoir for continued transmission. Public health programs or control efforts mainly rely on prompt detection and treatment of VL, but also indoor residual spraying. And this means they spray insecticides on the inside walls of dwellings. Of note is that indoor residual spraying, or IRS as we call it, takes up over 85% of the entire national control budget for VL in India. It's very expensive. Whereas the prompt detection and treatment is part of the regular care, basically combined with some active screening campaigns in villages where recent cases were reported. Now, the WHO has set the target for this disease to be controlled or eliminated as a public health problem, as they call it, by 2030, defined in terms of having less than 1 reported VL case per 10,000 capita at the local administrative level, which is called a block in India, which is about 100,000 people. Less than 1 death, reported death again, and to detect and treat PKDL. So these are very operationally oriented control targets rather than epidemiologically defined targets. Now, because IRS is so expensive, a relevant question is what does it actually contribute to the effective control of VL? And the problem is here, we don't really understand the biology of the sandflies. If you ask an entomologist, where do the sandflies live? How do they procreate? Where do they bite people? Nobody knows. Yet we are spraying the insides of houses for 85% of the national control budget. So, but you know, there's a group of people that are very keen on IRS and believe in its effect. So the question is, what does that contribute to achieving the control targets? Well, that's a very difficult question because it's very hard to disentangle from, say, secular trends, first of all, and those can be secular trends in, say, the use of insecticides in agriculture, which is happening everywhere in India, but also second, secular trends in detection rates of cases, which have changed considerably over the last 20 years. So the thinking is that IRS decreases sandfly abundance and therefore transmission. But if you can maybe imagine, if you spray it indoors, it may not just reduce the abundance, but also repel the sandflies, which is a different mechanism from a modeling perspective. Because remember, to transmit an infection, you need 2 vector bites, one to pick up the infection and the second to transmit it to another person. And if there's a repellent effect of, say, bed nets or IRS or some other sort of intervention, it's less likely that the second bite will occur. So the transmission probability of the disease goes down. So this means that in a rather indirect way, we can ask ourselves, do VL case numbers decline as expected, or more so based on trends in sandfly abundance? Thinking that IRS decreases the abundance, but if IRS has an additional effect, then we'd expect the VL incidence to decline more than just based on vector abundance. Of course, we have to account for secular trends here. So secular trends in the improvement of detection rate, for instance. And we did this work using a mathematical model based on earlier work together with Graham Medley from the London School of Tropical Medicine and Hygiene. The data set that we're using is quite unique. It was collected by the Liverpool School of Tropical Medicine by Michael Coleman, who has collected and is still collecting twice per month with CDC light traps sandflies in around 900 houses across 50 villages in 8 blocks in India. And between 2017 and 2021, they caught over 230,000 sandflies. 0 of them were infected with VL, and yet VL is ongoing transmission. So this only demonstrates how hard it is to understand VL transmission. We know the sandflies are the culprit, but it's very hard to detect infection in them. But at least this tells us something about the abundance of the sandflies over time. In addition, his team collected extensive IRS quality assurance data where they actually sampled the walls of houses for the concentration of the insecticides. And they even did some genetic studies on sandfly populations to check for resistance. So that's on the entomological side. The other side of the story is the reported number of cases which are collected or registered in the so-called CAMIS system, which is a national system for reportable infectious diseases in India, which is managed by CARE India, sponsored by the Bill and Melinda Gates Foundation. And from this system, we have village level case numbers since 2013. Before 2013, this system didn't exist, and we only had state level summaries, which don't really tell us very much about, or cannot really tell us very much about local transmission. So we have numbers for clinical cases, detected cases, PKDL cases that were detected. And for every case in the database, we know, or we have an estimate of how long they had fever before they were diagnosed with VL. So that's a measure of detection delay and a measure of basically the detection rate in the healthcare system. This is a summary of the data that I'm showing here. On the left are the abundance figures twice weekly across the 8 blocks that were part of this study. You can clearly see a seasonal pattern with a peak around July and August. And the bands across the shaded bands across the lines, or along the lines, are represent variation between villages within the block. So in each block, about 18 villages were sampled. And then on the right, we have the case numbers from the registry, which have come down considerably since 2013. And the gray area in that right panel represents the time period for which we have these vector abundance data. So now the question is, how well do these trends in case numbers in that gray area correspond with the fly abundances on the left side? And to do that, or to examine that, we decomposed the patterns in fly abundance into monthly relative abundance in the top right. So you see in July and August, the fly numbers are highest. And then per year, over the years, we see a general decline in the case numbers across all the districts. At this point, I can't tell you whether this is due to IRS or not. This could just as well be a secular trend, but we're going to ask ourselves, is the decline in the case numbers due to the decline in the sandfly abundance as we see it, or is it more than that? So first, let's look at the correlation of monthly abundance and monthly case numbers. Well, the colored lines here are the case numbers per block across the years, and each line represents a different year, and it's just very noisy data. The case numbers are so low, it's very hard to say anything about it, whereas the dashed line represents the relative fly abundance across the year, and that has a very strong signal, but you can't really tell anything. And even if you look at the average over the years, it's basically a flat line for the case numbers. Now, this doesn't mean that we should just assume that these are not related, because we know from historical analysis, from data from 2011, for instance, just before this study period started, in highly endemic area, there was a strong correlation between case numbers and the vector abundance. So the case numbers typically peaked around the start of the year, about half a year after the vector abundance was highest. And this is due to the fact that VL infection develops very insidious, taking months to produce symptoms and for people to seek out healthcare. So we chose to still capture still link this, capture the seasonality and vector abundance in the model, even though we don't directly see the result in the case data. Then for the annual patterns. So here I'm plotting the annual relative abundance on the horizontal scales and the annual VL incidence on the y-axis. Either in the same year on the left, in the left panel, 1 year apart. So the VL case detection in the next year versus the vector abundance in the previous year, or with a 2-year lag. And we see that the correlation becomes stronger with a 1-year lag, which makes sense because cases typically occur after the turn of the year. Whereas with the 2-year lag, doesn't seem to change very much. Overall, from this figure, I would conclude that there is no universal association between sandfly density and case incidence because it's just noisy. So we would have to model the association separately per district. And going back to the care team who know the field very well, I asked them what's going on with this one block called ROLE. Are the living conditions different there? Yes, they are. People there, they live in plastered houses rather than thatched houses with thatched walls. So that explains perhaps why, despite having a low fly abundance measured in the house, there's still a high VL incidence because maybe the people are getting bitten elsewhere and not inside the house. But then again, we don't know exactly where that is. But this, to me, speaks as if people are certainly getting bitten outside as well.
Can I just ask by what criteria is the 1-year lag better correlated? And then if you use a mixed effects model or whatever, you find that they're all correlated? Yeah,
good question. I haven't done any statistics on this. I'm going to go through a mathematical model with this. But you could do a correlation analysis on this, certainly. So I was just judging based by eye, really. So to capture the secular trend in detection delays, we analyzed the distribution of duration of fever before diagnosis across the years, and it was rather noisy and variable, though it seemed rather stable between 2013 and 2001, with some exceptions where only a few cases were detected. And for instance, here in Bihar, Varishngar, there was a certain year with only very few cases that happened to be detected quite late or had fever for a very long time. So in our modeling attempt or exercise, we assumed that the average detection delay in this period was about 30 days with a lot of variability between individual cases. Now, all this data, the entomology, the VL cases, the detection delays, we integrated in a mathematical model, which I won't go into too much detail here, but I'm just showing it to you to illustrate that it's quite elaborate in how it captures latent infection on the left side with low serological titers, development to late stage infections when the titers become higher, and then eventually a small fraction of the individuals become symptomatic. And once a case is detected, they will be treated and enter a dormant stage from which they can develop PKDL or recover completely. And all cases can be reinfected or sometimes reactivate. We believe that parasites will always remain in the body and sometimes trigger the immune system, and people can spontaneously seroconvert. Now, these are, of course, a lot of parameters which we informed with literature. Again, I'm not going through the details here now, but I want to highlight one aspect, and that is again related to the secular trend in detection delay. So the rate at which people are detected and treated, we assume that before we observe these data, between 2010 and 12, the detection delay decreased from about 90 days to 30 days. And we know this from historical literature and historical data sets. And back when the detection delays were 90 days, it meant that half of the VL cases died before they were even detected. And once that detection delay came down, we see in the global VL data, there's a spike in the case incidence, but that's purely because we're actually detecting them. Now, this is what the model predictions then look like. We trained the model using the first few data points in the time series for VL case detection, and then held out the tail of the data, the open circles.
Sorry, were all the distributions in the previous one exponential?
No, they were not. Some of them were Erlang, if that means anything to you. Yeah. So we do allow for some flexible modeling here. Right, so in the gray bar on the screen here is that period when the detection delay reduced from or declined from 90 to 30 days, where we see a spike in case incidence in some of these areas, and then a further decline following the data that was fitted to. And then if we zoom in on the held out data, we see that the model predictions agree pretty well with the observed case numbers, suggesting that there's no clear evidence that the case detection or the case rates declined faster than one would expect based on just the vector abundance. So unfortunately, we can't say for sure that that IRS has a repellent effect. But then again, if the case detection delays in the data are underreported because of convenience, these are just numbers that clinicians put into the system, it might well have masked the potential repellent effect of IRS. The analysis that I've shown you here is not yet telling us anything about a link between IRS and the actual decline in the vector abundance over time. So that's the next step for which we will perform a statistical analysis of the IRS quality at the household level and the actual vector number of sandflies caught in the individual CDC light traps across the 900 households. Have a quick look at the time. We're at 25 minutes now. So before I dive into the next case, maybe it's good to briefly pause and check if there are any pressing questions for clarification. Richard. Yeah, and then Kate.
Okay, just one. So with the model, you showed that the trends kind of aligned with case data, and you said therefore, it's what we'd expect. But did you do any sensitivity analysis to see like what would it take to not see what we would expect, kind of thing? Like, so
that is certainly on the menu, and I didn't even discuss several uncertainties with you, like how infectious are the latent infected people, because that's a very important determinant of the dynamics of the system. Yeah, we're still working on that. Yeah. Kate?
I just wanted to ask, why did the diagnosis time move from 90 to 30 days, which is like improved detection?
Yeah, it was because of increased awareness of health workers, basically. And at some point, they also rolled out surveys, basically going out to endemic areas and doing fever camps.
As fever, what does that mean?
Well, you go out, you ask people, have you had fever for how long? And then if they've had fever for more than 2.
I thought you said fever camps.
Okay, thanks. Yeah. Okay, I think we should move on for the sake of time. Thanks for those questions. The second and third case study are slightly shorter. So the second case study is to illustrate how mathematical or simulation in this case can inform guidelines. And in this case, we're looking at monitoring of drug efficacy in soil transmitted helminths, or STH. So STH are intestinal helminths that are transmitted through open defecation, poor hygiene, and bare feet walking. And approximately 1 billion people were infected, at least in 2010. And several control strategies are being implemented, including preventive chemotherapy with benzimidazole derivatives. But improved access to water, sanitation, and hygiene is, of course, very important in the long term. The diagnosis is typically made by examining stool samples and counting worm eggs under the microscope. And the goal of the control efforts is to reduce morbidity, which they define as reducing the prevalence of high intensity, moderate to heavy intensity infections below 2%. Preventive chemotherapy, oh, we got some echo here, sorry. So preventive chemotherapy is typically implemented annually or semi-annually. At the school level, sometimes in some sites, and usually in a study setting community-wide. And most of these drugs are donated by pharma. The concern is really that preventive chemotherapy alone is unlikely to interrupt transmission everywhere. And that's because we're either not targeting the majority of the hosts having the parasites, or the transmission is just too intense. And it's believed that wash is really necessary to interrupt transmission everywhere in the end, which makes sense. However, it's expensive and slow, hard to scale up. That being so, there is the concern of a risk of drug resistance developing in human worm species, particularly because in veterinary parasitology, resistance against benzimidazole derivatives is widespread. And in the STH community, people are flirting with the idea of scaling up to community-wide rather than school-based deworming, meaning that the selection pressure on STH populations would increase. So this is an added argument for, we should look out for drug resistance. So how can we best do this, given that our resources are finite? Well, the WHO recommends that we perform surveys where we select a bunch of people, we take their stools and then treat them, and then examine their stools again and count the eggs and see how much the egg count has reduced in that group of people. However, to save resources, they recommend that you only retest post-treatment those individuals who had at least one egg pre-treatment. That way you save money that you would otherwise spend on people that have zero counts anyway. That is the thinking. However, from a statistical perspective, this is problematic because it causes regression towards the mean. And I'm going to explain what that is, which leads to overestimation of drug efficacy. Now, what does that look like? Let's consider a fictive study, a survey in the field where you sample 200 individuals and you treat them with a fictive drug that doesn't do anything. This is the parasite population is completely resistant, suppose. So this is a graph of the pre and post egg counts across the population, and they are same before and after treatment because all the parasites are resistant, basically. Now, if we link the individual measurements across the population, you get this jumble of lines. But if we look at subgroups of these individuals, say the people who had low egg counts at the start of the study, you see that by the end of the study, they have, just by random variation, have moved towards the mean, whereas the people with the high egg counts have also moved towards the mean, but down. This is a naturally occurring phenomenon that's called regression towards the mean. Now, what happens if you exclude the people that were zero at start? You're going to overestimate the pre-treatment egg count. You will somewhat overestimate post-treatment egg count, but to a lesser extent, because that group has regressed towards the mean, but not completely. which means that you overestimate drug efficacy. This trial design will tell you that the drug actually did something, whereas it didn't. So what we did is a Monte Carlo simulation study to illustrate the effects of this flawed WHO recommended survey design. And we considered several alternatives that were still cost efficient to detect drug resistance. The approach was to repeatedly simulate SDH drug efficacy surveys for a series of scenarios pertaining to pre-treatment infection levels, the actual drug efficacy, how many people you select, and which subselection, or whether you do a subselection or not. We did this accounting for diagnostic variation in fecal egg counts and budget constraints. So we fairly compared the different survey results by restricting them to the same budget. So if you want to do like more egg counts, more K2-CATS fecal slides, the diagnostic test per person, you're going to spend more money on the diagnostics per person, meaning that you can test fewer persons, but you'll have more accurate information per person. So these are the things that we're trying to trade off: accuracy versus bias in the end. And well, in this graph, we're showing the estimated efficacy from a study versus the true efficacy as the dashed line. And the WHO recommended design is smack in the middle, and it completely overestimates the drug efficacy in this particular example. Whereas on the left, the three box plots represent a design where you don't select anyone, you just retest everyone after treatment. Means you're spending more money and you can test a few fewer people, but it's not so bad. At least your bias is zero. And then on the right, we have a design where we do select the egg positive individuals at the start, but then we ask for a second sample. And we only use that second sample in the analysis of drug efficacy. So we discard the results on which the screening was based. And this completely removes the bias as well, although the precision of the survey results is slightly lower than if you don't select at all. So concluding, we think that the WHO recommendation to select egg positive individuals should really be adapted, and we're actually helping the WHO revise their manual for this type of survey. Like I said, the precision of this so-called screen, select, and retest method, the right three box plots, is generally lower than the no selection design, but there may be an added advantage here. For instance, if you want to do a genetic study into correlation between particular polymorphisms and drug efficacy, you want biological material. And the SSR design, the screen select and retest, will give you more samples with more eggs. So that may be a consideration to choose for that design. Right, this was the second case study. And then the last case study is even briefer and more high level, and it's about my first NTD love, onchocerciasis, which was the topic of my PhD thesis in 2013 already, a long time ago. And with this case study, I want to illustrate how we use models to predict the impact of past, current, and future interventions. Onchocerciasis or river blindness is caused by a long-lived nematode. They live up to 10 years on average. They are transmitted by black flies. The target is for this disease to be eliminated in most endemic areas by 2013, like really interrupt transmission. The current intervention strategy is annual mass drug administration with ivermectin, meaning that all the whole population of age 5 and above is treated annually or offered treatment annually. And this is typically community directed, so it's done by volunteers. In some areas, there's also vector control, though I won't consider that very much in the remainder of this case study. The challenges with onchocerciasis control is really because of the long lifespan of the worm and the fact that ivermectin doesn't kill the adult worms, it only kills the microfilaria. MDA programs need to go on for many, many years, over decades, a decade, sometimes decades. in certain highly endemic areas. And it's very challenging to maintain adequate treatment coverage. Now, this is compounded by the fact that in some areas, another worm species is present called Loa loa. And if you have Loa loa and you take an ivermectin treatment, you are at risk of developing severe side effects. And if your Loa loa infection has a really high intensity, you may even die from it. So this is a really severe risk. And as a result of this, mass drug administration has not been implemented in some areas where onchocerciasis was just not very endemic, but still present. But it was not worth the risk of implementing ivermectin there. But now that we are moving to elimination, we kind of have to deal with these areas. So a few years back, the NGO Drug for Neglected Diseases approaches me with the question, look, we are developing this new drug that potentially kills adult worms. We would like to know how many cases of infection and morbidity will be around when we hope to finish developing this drug around 2020 or 2030, and how many of those cases will be amenable to treatment. So we performed a synthesis of data and expert knowledge using mathematical modeling, and we collated a whole bunch of data on the historical pre-control mapping of onchocerciasis and Loa loa in Africa, translated that to modern measures of infections using a whole bunch of statistical models. Then we have data on field surveys on patterns in incidence and prevalence of infection and disease, so particular symptoms and how they change over time during MDA. We combined that with expert knowledge on the mechanics of, or the biology, really, of how exposure to infection leads to disease, and we captured that in our mathematical models. And then we feed those models with data on the timing and the population coverage of MDA rounds. And we project forward in time for several different future scenarios of onchocerciasis control. We used ONCHOSIM, an established microsimulation model or individual-based model. This work was done by Natalie, a PhD student of mine who just defended her thesis last week, which I had to attend at 3 a.m. in the morning. So that was, it was worth it. It was really good. And she did a really great job at using ONCHOSIM to simulate the impact of MDA on onco in Africa. So ONCHOSIM is an individual-based model, meaning that we are simulating village populations, which are populated with individual humans, and the individual humans are populated with worms. And all of these humans and worms, they have life histories that we keep track of, including development of disease and production of worm offspring and transmission between people via the black fly vector. In addition, the model captures individual participation patterns for MDA rounds and the effects of treatments on individual worms in the host. And that includes the killing of the ivermectin kills the microfilaria, the larval stage of the parasite, but it also temporarily reduces the fecundity of the adult worms. So between treatment rounds, you'll see that the hosts, they have rather low levels of larvae in the body, meaning that they are unlikely to transmit. But then over the course of the year, close to the next MDA round, the microfilaria will come back up and they'll start transmitting again. So this is why also MDA programs need to be so long for onco. The model is also able to simulate vector control and, importantly, produce output for the expected survey results. This is an example of how we calibrated the model to pre-control patterns in morbidity versus infection prevalence across communities. On the horizontal axis, I have several measures of infection in different areas of Africa, and on the y-axis is the prevalence of blinding river blindness, so people who actually can't see anymore because their corneas have just completely grown shut with connective tissue from dying microfilaria. And that this is a highly nonlinear association where we see the prevalence rise steeply with higher infection prevalence pre-control. So we were able to reproduce these patterns with the model. Feeding the models with the information on MDA coverage, we predicted the number of cases of infection and morbidity up to 2030 with and without the MDA programs. So with the MDA programs is represented with the colored part of the bars, and then without MDA is the gray part. And the contribution of different types of symptoms to the disease burden, which this graph represents, is represented by the different colors. Some of these are reversible, like the navy blue are reversible skin symptoms. All the other symptoms are rather irreversible. And we see that MDA has mostly reduced the burden due to reversible skin disease, but that the irreversible signs, and that includes blindness, they take much longer to decline. So these are not really amenable to a new drug, for instance. But overall, the program has averted about 100 million, or will avert about $100 million by 2030. And by 2030, the burden will actually, the burden that is left over will mostly be in Nigeria and the Democratic Republic of Congo. Nigeria, because there are just so many people in the endemic areas, and some of the areas were very hyper-endemic at the start of control, and DRC because Loa is there. So they started relatively late with the mass drug administration. And in some areas, people just refused to take the ivermectin because they were scared of the side effects. So Natalie also had a look at the distribution of Loa across Africa, and using the models, we also predicted how that would change by 2025, and we see some decline due to the MDA against onchocerciasis, but mostly in DRC, not so much in other areas like Gabon and the south of Cameroon, less so, simply because MDA was not implemented there, because oncoendemicity was relatively low. Now, we asked ourselves, what will be the prevalence of onco and Loa co-infection by this time? And we see that the co-infection prevalence by 2020 will have reduced or declined considerably compared to pre-control on the left. However, still, if by 2025 we would want to implement MDA with ivermectin in these Loa endemic areas, we would have to screen 17 million people to make sure that about 160,000, so less than 1%, who are co-infected, don't get the treatment. So the test and not treat strategy, which is being advocated by WHO, for instance, it is valid, but it will be very expensive. With that, I finished the last case study. I hope that with these 3 case studies, I was able to give you provide a flavor of how models can help us increase our understanding of the impact of control efforts, but also inform study design, guidelines, and control strategies, and also evaluate policy impact. And what I really love about this work is that it really requires transdisciplinary conversation and collaboration. And this is also why I love being here in Sydney, being able to work with people like Susanna and her team who do the hard work in the field, and hopefully adding to the impact of their work with modeling. Thank you.
Thank you very much. Thanks a lot, Luc. I can see the questions on my phone, so if people have questions, please type them on the Q&A. And if anybody in the room has questions? I have a question, maybe, or just kind of a request for clarification. The estimates of DALIs averted are based on what, ongoing MDA? Because I know there's, like looking at that map, there's actually quite a lot of unknown areas, and there's also area of unknown endemicity, and also for areas where they are known to be endemic, there are no MDA
Mhm.
in place. So your estimates were based on the assumption that they will start MDA, or is based on what you know now?
Yeah, it's based on what we know now, first of all, and in most areas where we don't know the endemicity, they wouldn't be captured in this analysis. We used the data that was available at the time to us. This was 2018 or 17 when we started this work. And we assumed that in hypoendemic areas, so low endemic areas where lower is present, somehow MDA would be implemented at some point between 2023 and 2025. But in the end, that didn't really matter, because the most of the disease burden is really in the other areas that have already been subject to control for quite a long time. I mean, there are many people in these hypoendemic areas, but the disease burden is relatively low because of this highly non-linear association between infection prevalence and disease burden. But it is true that there will be residual infection and morbidity in those areas, but it will be relatively little compared to what was there in the other places.
Okay. Well, I was just wondering, well, because if you're like doing this to provide an answer to, you know, that can encourage or discourage pharmaceutical companies, it would be important to also include the places where I guess there is no MDA, but there could be, so that will contribute to a lot of dies.
Yeah. Well, some of these areas are included in the analysis because we knew they were probably hypoendemic, but there was no MDA. But there's probably still areas that are now being targeted with the so-called onchocerciasis elimination mapping that at the time were not yet part of the data.
Okay.
Yeah.
Any questions from the room?
I guess for just onchocerciasis and leishmaniasis, like knowing the distribution in time from infection to potential illness or diagnosis and treatment, I just wondered how well that was understood. It seemed like quite an the graph that you had for the leishmaniasis, was that because there was a one-off seasonal exposure in an area, and then looking at the delay until.
So I'm not sure.
You had a graph where you said that the mean time to diagnosis was 6 months.
Yes.
And I was just wondering, was that a place where there was no infection and then it came in on a peak?
Oh, I see. Yeah. Well, typically what happens with VL, it seems to be like the endemicity seems to be stable at a high geographical level, but what actually happens on the ground is that the village will not have anything, and then for 2 to 3 years there will be a massive outbreak, and then it will suddenly, VL will disappear again and will have moved on to another village. So yes, these outbreaks are highly localized and very peaky indeed, with the peak occurring around the change of the year.
And the fact that it's flat in all your ones above is because you're averaging it over a larger geographical region, or
so I suppose because these are numbers for an entire block consisting of about 100,000 people, and a village is about 500 people, so there are about 200 villages in a block. But if you start looking at the village level data, it's all zeros and a few high numbers, and that's even harder to model without a meta population model, but we're trying to address that.
I was going to ask about the modeling of the villages. So just with that, the movement, do I understand why suddenly the peak? Is it like a migration, like people moving to that village, or is it?
I don't know if anybody really knows, but I would guess it has to do probably with, for instance, girls marrying at 15, moving to the in-laws in another village. That is a major driver of permanent migration, at least. But maybe also like a regular trade and movement of people plays a role.
Could also be a diagnosis bias, because once one person's diagnosed, suddenly you worry a bit more about your fever.
Does that mean so like someone is infected in a village that has an outbreak, and then they move to another village and they're a reservoir in the new village, and
and that case could be a person with PKDL, like the chronic late stage, which they're not bothered by, but they're infectious. Or it could be a person who has a latent infection, which most of the time doesn't really turn into anything, and maybe has a very small chance of transmitting to a sandfly.
an MDA rather than just PKL screening?
Oh, well, up to a few years ago, treatment for VL was highly toxic and you needed like an IV for it. And you could turn blind from it. And then recently the, liposomal amphotericin B, I think it's called, is a one-off drug treatment, but it's not cheap and it's certainly not donated.
So there's no MDA for a VL,
Yeah.
basically. I have a few comments online. Sorry, then I'll come back to the room, give you a break. So a couple congratulations on your talk from Jonathan and Nicholas, and Adam is asking, besides complimenting you as well, how often do you proceed to repeat modeling to inform public health policy as more data becomes available? I don't know. Good news that the onchocerciasis, for instance, I guess that's related to what I was asking, as you know, like as people scale up or down MDA, if you adjust things or retest.
That modeling was, it started with my PhD thesis over 10 years ago, when APOC, the African Program for Onchocerciasis Control, actually asked us to do this type of analysis purely really for advocacy, to make sure that we demonstrated that it was useful to have a program that cost maybe a few $1 million a year. It wasn't that expensive, and to see how much impact it had. So this modeling has certainly had an impact that way. Then what was the rest of the question?
Yeah, if you repeat.
Oh, and then check whether it actually worked out that way.
Well, that could be as well,
Or
or to update. I mean, I guess
Yeah.
either to update predictions, or if you say this was done 10 years ago, and to update predictions, or to confirm. Yeah.
So I originally did this 10 years ago, and then Natalie did an update based on the new programmatic data, including more symptoms. It's very hard to actually compare these estimates to field data, because people don't go out to the field and actually do surveys about the morbidity of onco, because that takes a highly specialized ophthalmological and dermatological team. So, but for VL, for instance, we are going to, for instance, try get Liverpool School together with some serology experts to actually do antibody measurements in these fields where in these areas where we actually know the vector abundance, and get a lot more direct measure of what is going on in people. And then hopefully feed that back into the models and see how well that correlates with the case numbers.
Okay. Any more questions here? Here, yes, I'm done here with, you have time for one more, or I'm not sure if this makes sense what I'm going to ask, but you know, like for instance for STH, where there's a lot of kind of spatial clustering and heterogeneity in a given country or given province, right? And you did show some maps, but I'm not sure if what those maps were, if they were just sort of point estimates made broad for a given area. I guess I'm just trying to understand if there is a point where geostatistical modeling and kind of risk predictions can overlap with mathematical modeling, where there's prediction of impact of an intervention, but have that information instead of, like, you know, as when I look at your papers, like it says, you know, like X rounds of MDA will lead to whatever reduction. Is there a way of seeing these visually?
The Bill and Melinda Gates Foundation have asked us this many times. And it is certainly it is a field of active research, I should say, and with a neglected modeling neglected tropical diseases modeling consortium, not the neglected modeling consortium. We are working on that. It is very challenging, because the issue is when you apply a mathematical model to a map, you have to either somehow capture that what happens in one pixel of the map is somehow correlated with another pixel, but that's actually very hard to do with a model that's not spatially explicit.
Just going to be similar to my question. I was going to ask about ONCHOSIM being like how granular, like it's individual based, but a village based, or sort of, you know, area based, so we can focus.
That's a very relevant question. So what we do in this exercise, we take a district or an area, an implementation unit, and we check how many pixels fall in different categories of infection intensity. And then for those categories, we make predictions. And that works fairly well for predicting trends in morbidity. That won't work for predicting elimination, because then the dynamics become, the stochastics of fade out become so important. I don't have an answer to that yet.
Okay, well, I think we're approaching 2 o'clock. There's no more questions on chat. Any more quick comments? Well, once again, thank you very much, Luc. I know there will be continuations with the Kirby colleagues and mathematical modelers, and Luc is going to be around until the end of this week. So if anybody wants to say hi or ask questions, feel free to reach.
6th floor.
Yeah. Okay. Thank you very much for everybody for your attention.